Assalamu alaikum. I'm Dr. Ramisha Zahid Shah, consultant histopathologist. And by now, we are done with most of the B cell lymphomas. So, we are going to quickly recall their IHC profiles in this quick video. But please keep in mind that morphology is a very important factor in diagnosing lymphomas, and so is the importance of molecular studies, which is considered mandatory in a lot of lymphomas now. We are going to the IHC profile now, and let's see what can we recall. So first, we are talking about lymphoma. Of course, it's a B cell lymphoma. It is CD20 positive. CD5 is also positive in the same population that is staining the CD20 cells. CD23 is positive. LEF1, cyclin D1 is positive in proliferation centers. Yes, it is CLL/SLL. In another scenario, we are encountering another lymphoma that is CD20 positive, CD5 positive. Cyclin D1 is positive cell to cell, and it is CD23 negative. So we are talking about a lymphoma that has small cells. We have ruled out CLL by ruling out the by CD23 negativity. Cyclin D1 here is cell to cell positive, which means there is a molecular signature to it. Yes, we are talking about mantle cell lymphoma. Now we are talking about a lymphoma that is CD20 positive, BCL6 and CD10 positive, and BCL2 is positive in germinal centers, which is not seen in a normal lymph node because normally the germinal centers are BCL2 negative and BCL2 is seen in the T cell population. So in this lymphoma, we have BCL6 and CD10 positivity, and BCL2 is seen in the germinal centers. CD5 is negative. So here we have ruled out the other two small cell lymphomas. And the morphology here is most likely follicular, and it will show follicular lymphoma. Then we have a CD20 positive, CD43 positive lymphoma. And now we are excluding the other lymphomas. So we are excluding CD5 is negative, CD23 is negative, cyclin D1 is negative, and CD10 is negative. Any guesses here? Well, this is nodal marginal zone lymphoma. And when we diagnose nodal marginal zone lymphoma, we have to rule out that it is not associated with any other lymphoma of marked sites. And it is, we diagnose it by excluding metastasis, and we diagnose it by excluding other lymphomas that have small cell morphology. Next is CD20 positive, CD38 and 138 positivity. So this indicates somewhat plasmacytoid morphology along with CD20 positive B cell population. But CD5 is negative, 23 is negative, cyclin D1 is negative. Again, ruling out the lymphomas with small cells. And we have CD56 negativity, which means that it is not a plasma cell neoplasm. So this is lymphoplasmacytic lymphoma, indolent lymphoma, but incurable. CD20 is positive and now next we have to assess CD10, BCL6 or MOM1 status, and then we assess MYC and BCL2 status. So this is, we are talking about the large B cell lymphoma. Of course, the morphology is going to be very helpful here. Just a recall that these are the few things that we must assess. First, we have to determine the germinal or post-germinal status, and then we determine MYC and BCL2 status, so we know that whether it's a double expressor or not, and then we recommend FISH so that we know that either it is a high-grade B cell lymphoma or not. So there are a few things that we assess here. First of all, we determine DLBCL, then it's post-germinal or germinal center origin, whether it's a double expressor or a high-grade B cell lymphoma. Now we come across a lymphoma that is B cell and T cell markers negative. However, it is CD38 and 138 positive. CD30 is positive, and EBV is positive. So 38 and 138 are going to indicate plasmacytoid morphology, but with this profile, B and T both are negative. So we will diagnose it as, after considering the morphology, definitely, it is plasmablastic lymphoma. Then another case where we come across B and T markers negative, CD38 and 138 is positive, but CD30 is negative while ALK is positive here. Please be careful that we are not talking about T cell lymphomas here. It is still, although the B and T both markers are negative, it is a variant of large B cell lymphoma. It is CD38, 138 positive, CD30 is negative, and ALK is positive. So this is ALK positive large B-cell lymphoma. In another scenario, if B and T are negative, CD20 can be weakly positive, CD38 is positive, and HHV8 is positive. So this is a very simple scenario. It's HHV8 positive large B-cell lymphoma. And then is CD20, 23 positive, and CD30 positive. So now we have markers from B cell lineage. We have CD23, and in addition to that, we also have CD30 positivity. Well, any guesses here? The hint is that it is in the mediastinum, and it is mediastinal large B cell lymphoma. These large B cells stain not only for CD20, 23, but also CD30. And then we come across a case where the cells are positive for TDT and CD34. PAX19 and CD19 and PAX5 are positive, but CD20 is weakly positive, almost negative. Well, yes, that is B, lymphoblastic lymphoma. TDT is the marker for blast, and so is CD34. A similar case, TDT is positive, CD34 is positive, CD1A and CD5 are positive. Site is mediastinum. Again, the markers for blasts are positive here. Site is mediastinum. Oh, thymoma. Well, let me emphasize here the importance of morphology and history, because thymoma is not seen in children, very rarely seen in children. So how we determine here, the very small biopsies can be tricky, because thymoma and T lymphoblastic lymphoma have an almost similar IHC profile. So we need to consider morphology and history of the patient, and also a small CK stain here is going to help us a lot in differentiating T lymphoblastic lymphoma from thymoma, which is an important differential. Last but not the least, we have a tumor, a lymphoma, that is CD20 positive, CD10 positive, MYC is positive cell to cell, and BCL2 is negative, and so is TDT. We are talking about a child over here. TDT is negative, so it is not lymphoblastic lymphoma. And this is a very characteristic profile for Burkitt's lymphoma. Burkitt's lymphoma is negative for LMP1, while it is positive for EBER and EBNA. So here's a quick recall of B-cell lymphomas along with T lymphoblastic lymphoma. Thank you for listening.